Everyone, good afternoon. Thank you so much for joining us for this timely and important virtual conversation being hosted by Policy Lab at the Children's Hospital of Philadelphia and the Sprout CTSA Network, a multi-centered collaborative research network dedicated to establishing an evidence base for pediatric telehealth. I'm Kate Wallace, a faculty member at Policy Lab, an attending physician in developmental and behavioral pediatrics at CHIP, and assistant professor in the Department of Pediatrics at the University of Pennsylvania. So for today's event, I'm thrilled to welcome pediatricians, researchers, policymakers, and family advocates who will discuss innovative ways to create telehealth policies that provide more equitable access to pediatric specialty care for families who have been left behind by the initial wave of telehealth implementation. We will also hear from them on future directions and promising solutions to continue to make sure that telehealth is available and used in a way that is equitable and accessible. A couple of reminders for those listening in to today's presentation. All attendees' lines are muted and video will be disabled throughout the event. We are looking forward to a robust discussion following some of our opening remarks. So if you'd like to submit a question, you can do so at any time using the Q&A feature located on the right-hand side of the platform. And my colleague, Radha Panati, who serves as a policy and strategy manager here at Policy Lab, will be monitoring the questions and will turn to them after the initial presentations. So first, I'm going to set the stage for today's presentation. Like it or not, I'm going to take you back to the spring of 2020. And within developmental and behavioral pediatrics, we were urged to cancel any non-urgent appointments to limit the spread of the then novel coronavirus. We had at least 6 months of appointments booked and a long waiting list of patients eager to be scheduled for assessments. We were faced with a choice: make families wait an indeterminate amount of time for an in-person visit, or adapt our practice to have children assessed by telehealth. Within a matter of weeks, we were seeing children for autism evaluations as well as other assessments in their homes remotely by video visit. However, we didn't know much about how providers and families felt about these visits, what was going well and what was not going as well. So to fill this void, we quickly began a study to capture the changing practice landscape in developmental and behavioral pediatrics. We asked participants to complete surveys and interviews, and we included developmental and behavioral pediatric providers and caregivers who had participated in a telehealth assessment for possible autism in young children. We found that acceptability across both groups was moderate to high, and that both providers and families wished to continue to have access to telehealth for developmental behavioral pediatric care. In fact, we heard about some particular advantages that participants noted for families of young children with developmental concerns and having their children evaluated in their own homes without having to travel into potentially stressful clinical offices. However, we also identified that some groups were facing more challenges when it came to telehealth. These included families who speak languages other than English, those who experienced technological barriers like poor access to devices or to high-speed internet, or those who have less comfort using digital devices, families experiencing housing insecurity, and those without a private or quiet space who have multiple children or fewer adults at home to help manage the visit. So the findings of that study are about to be published in the Journal of Developmental and Behavioral Pediatrics. And we're thrilled today to have the opportunity to speak with experts to help us contextualize those findings, think about solutions to the issues that we uncovered, and help us envision the future of telehealth. So with that, before I dive in, I'd like to introduce our panel of speakers. So first up, we have David Bentz, who is the Deputy Director of Healthcare Reform at the Delaware Department of Health and Social Services. Prior to his role as Deputy Director, he served as a Delaware State Representative from 2015 to 2022, where he was Chair of the Health and Human Development Committee. Next, We have Rosani Sanchez Algarin, who is the Director of Programs at Family Voices National, a national family-led organization of families and friends of children and youth with special healthcare needs and disabilities, where she focuses on organizational development across different projects that support underserved communities, inclusion in all aspects of family engagement and family-centered practices. And lastly, we have Dr. Sansoni Craig, co-chair of the American Academy of Pediatric, Sprout's Telehealth Equity Working Group, an associate professor in the Department of General Pediatrics, a primary care physician at CHIP's South Philadelphia office, and clinical informaticist in the Department of Biomedical and Health Informatics, who leads digital health equity and global health informatics initiatives at CHIP. So thank you so much to our panelists for joining us today. First, I'd like to start with Deputy Director Bentz to hear your perspective. So as we begin our discussion on equitable telehealth practices, I think it's important for us to understand how policymakers and state agencies have approached telehealth policy. As a Delaware state representative during COVID-19, you had a front row seat to the rapid uptick in utilization of telehealth as families sought safe alternatives to in-person care, and payment policy quickly shifted and became more flexible. Can you tell us, how was state policy supportive of equitable access to telehealth during the pandemic, and how is it not?
Thanks for the introduction. So as was said, I'm David Bentz. I am the Deputy Director of Healthcare Reform for the Department of Health and Social Services here in Delaware. Before that, I served as a state representative for 7 years, where I was chair of the House Health and Human Development Committee. So as we were sort of moving through the pandemic, a lot of the policies that the state adopted, first through emergency order, but then through legislation as we were able to get back into session, funneled its way through the committee I chaired, and got to work with the policymakers and providers and folks like that in the development of those. So as the pandemic unfolded, obviously there was the key issue to solve was how do you provide care and treatment in a socially distant world? And telehealth was obviously the tool that was most frequently cited as the best way to go about doing that. And a lot of that involved taking a look at our existing policies and how they maybe restricted access. And a lot of the key ones that we saw were how individuals who maybe lived in areas where there wasn't reliable high-speed internet access, who were maybe finding themselves some amount of distance from their providers or a lack of access to existing providers, how do you sort of connect those to address this equitability issue? So the biggest thing that we did, I think, in the early days of the pandemic was through the initial emergency order, we pretty much suspended all sort of regulations and sort of barriers to telehealth. Going forward, and how we tried to implement those in a more permanent basis once the initial emergency orders started to expire, was to allow for telehealth to be delivered by telephone as opposed to just video consults in the event that the individual didn't have access to high-speed internet, and in the event, obviously, that a certain standard of care could continue to be met in that manner. And obviously, the providers are very good at understanding when they can, deliver care through a telephone call versus a video call versus when they're going to need somebody to see somebody in person. So really just breaking down, I think that was the most critical barrier that we were able to break down, was that requirement that it couldn't be delivered unless there was a video component to it. And then, of course, you have to kind of go in and backfill then, right? Then you have to look at payment policies and make sure that Medicaid's paying for telephone consults, that private payers are paying for telephone consults. So it's really a multi-stage process where first you go after the regulations and the barriers, and then you obviously have to work with on the business side of this to make sure that it gets reimbursed appropriately. And the good news around all that, and I think somebody who's worked in politics for a while and in this current environment that we're in, it can be very challenging to get sort of uniform action on something, uniform support. But a lot of this stuff with telehealth and a lot of the issues that we were dealing with during the pandemic, and I guess we kind of come to a different phase of it, is one where there's really broad bipartisan support for expanding access and equitability. This affects all communities, right? This affects traditionally, maybe more democratic urban populations, and obviously impacts more conservative rural populations who are dealing with a lot of the equitability issues I discussed around having high-speed internet. So we were able to get a lot of political buy-in, so passing legislation wasn't particularly challenging to make the reforms we need to make here. It was challenging to write it, to work through with all the interested stakeholders and make sure you were doing things in a way that was going to break down those barriers while maintaining a good quality of care delivery for the affected individuals. So that was sort of my experience during that. It was really a 2-year period from the onset of the pandemic through emergency orders and then through sort of a reset of evaluating those emergency orders and what we could keep in place long term and what maybe couldn't stay in place long term.
Great, thank you for those comments. I'm sure we'll come back to some of that about sort of what has changed over the course of the pandemic and peri-pandemic period, I'll call it. So now we're going to turn to Rosani Sanchez-Algarin. Family Voices was very involved even before the pandemic in thinking about helping families gain access to telehealth, and your organization was conducting a needs assessment of families surrounding telehealth access. Can you share what that study identified and how your organization used that information to develop a curriculum to help support families?
Thank you, Kate. Hello, everybody. Well, with Family Voices, we had a 1-year project funding from HRSA, specifically from NCHB, which is Maternal and Child Health Bureau. Family Voices provide education and resources to families organizations to improve access to telehealth for families, specifically with children with special healthcare needs. Family Voices provide mini grants to more than 56 of the family-to-family health information centers to conduct activities in their states, including the territories and the tribal communities. We host a telehealth academy. We organize a community of practice. We develop a family-centered telehealth curriculum and other resources in English and Spanish. But to be able to develop all those activities, we conduct a needs assessment throughout our network, and that network reach out to all the families that they serve nationally. Some of the challenges and the barriers that families were able to share with us the biggest ones was language and technology access, which includes challenges with the different platforms that we use using telehealth, registration, internet access and connectivity, website navigation, also confidentiality. It was a big one too for families, insurance coverage, lack of understanding of the rights and responsibilities of the patient, and also resources available in the native language, among with others. Using the data that we collect, we were able to achieve the goals of our project, which were share with our network partners and stakeholders the best practices for serving families using telehealth, specifically families who were vulnerable, they are diverse, medical underserved, and really hard to reach. We also were able to identify and share strategies to overcome those barriers, to increase family participation and promote family engagement using telehealth services. And lastly, we develop many different resources that helps promoting family-centered telehealth in plain language, and we all the resources we were able to culturally adapt them to them. Thank you.
Thanks. I think when we get to our Q&A, we can talk a little bit more. I'm really curious about some of that cultural adaptation and some of what you shared with us in the preparatory work. So maybe think about some specific examples of what that cultural adaptation looked like for families, and we'll come back to that. So thank you for that. Next, I'm going to ask Dr. Craig a little bit about your work. So in your research, you define the digital divide as the technology, internet, design usability, and empowerment access gaps between marginalized populations and others. What opportunities do health systems have to close the digital divide related to telehealth access, particularly for families who speak and read a language other than English?
Thanks so much, Kate. Thank you for this opportunity to share my thoughts. I'm really optimistic. This is a passion of mine. I think there are so many opportunities for healthcare systems like CHOP to do a lot to close the digital health divide, especially for families and patients who prefer to speak a language other than English. And you mentioned that I'm a primary care pediatrician in South Philly, and I wanted to give just a little bit more context of where I'm coming from in my perspective. So I was born in Thailand, and I'm fluent in English and in Thai, although I prefer to speak with my healthcare team for myself and my children in English. Throughout my career, I've worked in various healthcare settings between Minneapolis, Baltimore, and now in Philadelphia, as well as global settings. And then, so I've witnessed a lot of different approaches for caring for communities with very diverse backgrounds, different language needs, cultural needs, specifically Hmong, Spanish, Amharic, Arabic. And this experience has really pushed me into this field of health informatics, which for those who don't know is really just thinking about the people's processes and technologies in healthcare settings and how to make things better so we take care of our patients better, particularly with a focus on equitable health outcomes. So I'm a mom of 3 boys, all CHOP patients. I'm myself a patient and consume a lot of these digital health tools, including telehealth. And so I really understand kind of the digital health tools, both from the design aspect and from the use of it aspect. So in my role, I really see myself as a bridge and a translator from medicine to technology, from technology to medicine, English to non-English, and vice versa. I've translated Thai to Hebrew, Hebrew to Thai, English to Thai. And so my perspective is I'm really bringing my expertise in medicine and technology to think about how do we design systems, healthcare systems, workflow systems to really address the needs of the healthcare professionals and the patients and the families we need so that we have equitable healthcare processes and outcomes. So when I think about thinking about CHOP, for example, or healthcare systems and the opportunities to really create the change for equitable digital health systems, I think of 3 different opportunities. So number 1, first and foremost, just make digital health equity a priority and a requirement across the institution, especially for information service teams, IS teams, digital health teams, and data and analytics teams. So number 1, make it a priority, make it a requirement. Digital health equity just has to be considered first and foremost in any initiative across the institution. Number 2 is design digital health tools with underserved communities, not for them, with them, so co-design. And I'll speak a little bit more about, I'll give some examples in a second. But then number 3 is stand up the human bridges. Where these interventions have failed, where we have tried to address design issues around that are within our own institutions that create these digital health inequities, where we put these kind of stop gaps into place, we're trying to do better, and they're just failing. We're just not crossing that bridge. We're not closing the gap. Then stand up human bridges. And human bridges, I'll give an example to overcome the digital divide. So those are my 3 kind of opportunities I see for healthcare systems. And I can go into some data and some stories for each of those points now or later. I'm not sure when's the best time. Okay.
Sure. If you want to walk us through some examples, I think now would be totally appropriate.
So make digital health equity a requirement. And what that means is, we all think about patient safety as a requirement. We would never create an unsafe app or an unsafe remote patient monitoring tool for families to use. I think that the same requirement just needs to become part of our everyday culture, where we would never make one that's inequitable, that would be exclusive of certain populations. So one example is if we look at our patient portal activation rates. So our institution uses a vendor software system called Epic, and the portal is called MyChart. In January of 2020, I started to look at the disparities in activation rates, who has an active MyChart account. And in January of 2020, for example, for non-Hispanic Black patients, it was 52% of those patients had an active MyChart account versus for non-Hispanic white patients, that was 72%. So there was a 20% gap. If you look now in January of 2023, that gap has gone from 20% down to 7%. So there is a gap then when it comes to who's going on to use our digital health tools. And one of the reasons that kind of changed and closed that gap was that we really thought about equitable access to our patient portal and put some interventions in place to try to close that gap. It became a requirement and it became a necessity in the pandemic to close that gap. Number two is thinking about designing digital health tools with underserved communities. When we think about research, we know a lot about community-based participatory research with underserved communities, but we don't really know so much about operationalizing community-based participatory design of our IS tools, our digital health tools, in a kind of an operational implementation sense. If we did, we might quickly realize that text-based interventions or text-based access points are actually much more meets the needs of underserved communities, more so than a portal that you have to create a username and password to sign in, and it might not even be in your own language. It likely isn't. So when we do co-design with underserved communities, we very quickly realize that we need to center their needs right in the middle of RIS transformations and digital health tools. And then lastly, standing up human bridges. So during the pandemic, CHOP stood up a digital health navigator program because we saw that there were disparities in race, ethnicity, language impaired groups of who was being able to complete a video visit. So we have a metric called a missed appointment or a no-show rate to video visits. And at the beginning of the pandemic, there's a similar 20% gap, just like we saw in the MyChart portal activation rates, between for those who had a video visit appointment, who was able to make it across the finish line and get that video visit done and completed. Now that rate decreased down to 20% because we stood up this digital health navigator program that are human bridges to help families kind of overcome all of the complex user interfaces that is inherent in the design of our digital health tools right now. And then just as a quick story, a lot of the digital navigator work was really birthed out of the really true, wonderful work that our PSRs and medical assistants were providing for our families to just say, you know what, I'm a mom, here's the app, here's how to get onto a video visit. And that kind of human bridge to overcome that digital divide was just so impactful. So those are kind of my opportunities as I see them for healthcare systems like CHOP to close the digital divide gap.
Great. Thank you to all our panelists for walking us through some of these really important questions and to help frame the rest of our conversation. So I'll ask some initial questions, and then I see I see some people starting to use the Q&A function, so I encourage everyone to ask any questions they might have, because we will then open it up to audience questions, and I'll help moderate that. So something that came up in our research is that families still want access to telehealth, particularly for certain types of care. Rosani, I was wondering if you can share from some of your work in this area, if you can talk about what some of the benefits of telehealth maybe that you've heard from families. So in particular, we found that telehealth was thought to be especially useful for families who needed help accessing subspecialty pediatric care, such as in developmental and behavioral pediatrics. And can you speak to this at all?
Yes, definitely. I mean, I can share both what families have shared with us and also my own personal experience as a mom of twin boys. I think one of the biggest benefits is how much time we have saved using telehealth services. When families have a child with special healthcare needs, leaving the house, it could be quite a process, right? So not only leaving the house is a whole process, but also where do we park and how far is the doctor office and everything that we have to do when we are waiting in that doctor office, right? So definitely telehealth appointments save families a lot of time, a lot of stress moments, and I mean, for most of cases, could be very convenient. Also, it's not, I mean, it's not required transportation. Believe it or not, we have many different families that we work with that they don't have transportation services. And in different states, I mean, I live in Puerto Rico, public transportation here is almost zero. So parents have to basically spend money to get a taxi or to get an Uber to be able to get to the appointment. So not transportation not being a requirement, it really helps and is a huge benefit for them. Another big one, like you shared before, the availability of having that specialty provider. Using telemedicine, I mean, families can see a specialist that they're not maybe accessible either because their full agenda or their location. So be able to see that a specialist is a huge benefit for them. And I mean, another one that is a big one, how much we can, I mean, families feel that is less stressful using telehealth. I mean, families have shared having a child in their own environment even help them to feel more comfortable, focus on, you know, what the doctor is saying. They able to take notes and ask questions, and they don't have to deal with all the behavior issues that they may have when they are in a different environment. So especially for pediatric community, I mean, telehealth is definitely a huge benefit.
That's wonderful. And that, thank you for speaking to that family perspective. I would say that that is very consistent with what we found in our project in interviewing families and providers, that especially for children with those developmental and behavioral issues and developmental disabilities that we are evaluating, not having to overcome that anxiety, the behaviors that often are seen in stressful environments like doctor's offices, made telehealth particularly attractive to this population, as well as when we were performing autism evaluations and children were located in their homes, we were able to really see them in their natural environments, and so be able to see their behaviors, their interaction with others, the way they played, what toys they had at home, those sorts of things all weighed into part of our assessment. And so that was a really nice benefit that we observed and that came up frequently in our study. So thank you for speaking to that. So I'm going to open this up to all of our speakers, but maybe we'll go in order. So there are a lot of actors that are involved in telehealth who are not squarely involved in the healthcare space. Can you tell us a little bit about some of the stakeholders that you've either engaged with or would like to engage with, and how you're able to bring equity and pediatric health needs to light in some of these forums? So why don't we start with David, since we haven't heard from you in a bit.
That's a good question. I think one of the groups I think that could play a big role here is the telecommunications companies in particular. And I think you have the biggest challenge that I see with this, again, is making sure that everybody has access to the technology they need to do this. So whether it's, you know, at this point, you know, just about everybody has a device that's connected to the internet in some way or high speed. But what we sometimes run into is issues where the lines themselves don't go there. I'm in a state that is very small. It does have a rural population area where high-speed internet isn't always readily available or reliable. We are working on that as a state. There's been a lot of infrastructure money that's gone into sort of driving us to getting to a place where high-speed internet's available everywhere. But even in, again, a state that's viewed as small and relatively, you know, sort of packed right in the middle of you know, the I-95 sort of super megapolis area of the country, we still run into it here where we have issues of access to the technology and the high-speed internet. So I'm curious again in how those sorts of companies can be sort of drawn into this to help alleviate those sort of shortcomings that still exist, especially in those last remaining areas. And I think that probably goes as even more of an issue. And I've talked to colleagues from across the country who either work in their health departments or in legislatures that are in states that are actually rural and isolated. When you start getting out into like the mountain states, and where you can go quite a distance between somebody and a healthcare provider. And those individuals really need access to telehealth services where it can really be a game changer for them. And they're also the ones most likely to be without the high-speed internet. So I think I question, what ways they can get involved to, achieve this that go beyond just sort of the economics of bringing in new customers, but also what that actually means to public health and to healthcare equity, these populations who are really isolated.
Thanks. Yeah, I think that makes a lot of sense, and something similar that we found, that there are populations who struggle to access in-person care, and sometimes those are the same populations that struggle to access telehealth care. But I think what you're sharing and thinking about sort of public-private partnerships to help bridge those gaps, it seems like there are solutions that are available to us there through that. Stancini, do you want to speak to the same question about other stakeholders you've thought about engaging with in this?
Yeah, so through the Telehealth Equity Working Group that I co-chair in AAP, and through Policy Lab health equity researchers like Nadia Daushin, yourself, I've been connected to Juliet Fink Yates here in the city of Philadelphia, who's on the call. Thanks, Juliet, for joining. She is the digital inclusion manager in the city's Office of Innovation and Technology, and she leads a digital health equity task force that she stood up in the last year or two. And I particularly love this forum because it's cross-institutional. So folks from Drexel, Temple, Jeff are joining. It's cross-vendors. We all use different software vendors for electronic health records. And this is such a really great, I think, stakeholder to bring into and kind of give folks in the city a peek into what's happening in our healthcare institutions from across a variety of folks. So this particular group of stakeholders, I think, is one to bring in squarely into the healthcare space. So the Digital Health Equity Task Force helps to bring in that healthcare perspective to help inform the city's digital equity roadmap. So the city of Philadelphia has a digital equity roadmap and a blueprint, and then this kind of helps to bring that healthcare perspective into that. And for those who are interested on this audience, you're welcome to join the quarterly meetings. The next one is happening in 2 weeks on a similar topic, equitable telehealth policies. So just reach out to Juliet if you feel like you want to put your email in the chat, or the organizers can send it. But I think that's another great stakeholder to bring in. For example, at the next quarterly meeting, the PA Broadband Development Authority is going to be joining to get feedback from everybody who's on the call around healthcare digital health equity needs and challenges as they build out the digital equity and broadband plan for the state of Pennsylvania. And I don't know, David, if you have something similar in Delaware, but this would be, I think it's a really wonderful way to be that conduit and voice from within healthcare systems directly to state and city bodies, and vice versa as well too.
Great. Rosani, I'm wondering if you have any insight into or have been a participant in any conversations and have been able to share some of the family perspective in that. And in particular, I was really struck when we were chatting before to prepare for this about some of those specific nuances, especially for families who speak Spanish that are part of Family Voices. And if you could think through, what are some of the particular challenges that you've had to sort of share with stakeholders regarding their needs?
Well, during the pandemic, we were able to work closely with different stakeholders, like Title V. I mean, we work closely with providers, American Pediatric Association, federal agencies, and we were sharing what we were hearing from families. I mean, where they were struggling the most. I mean, but again, most of the families, especially the ones that they are in the very rural places and areas, they don't even have a phone. They don't even have connection. So what was the option for those families? So it was very hard for them to provide services when they don't even have connection. So honestly, what we did during this time, we were collaborating with the community itself. I mean, the community, the faith, the churches, and the faith-led organizations were helping us to create private spaces for families to go and do their telehealth visit. I mean, it was a huge collaboration. I mean, in American Samoa, I mean, just giving you an example, we have families there that they're struggling with connectivity. They don't have internet speed connection, so they can't share a video camera for very too long. So we have to help them, providing those mini grants, which was a budget that we provide to the health information centers, so they can help and support that community, specifically the ones that they were struggling getting services. So, I mean, I think that we have to bring everybody at the table, especially with moments like this. I mean, a lot of times stakeholders have so many, policies and processes that families doesn't know how to wait. Right? And an emergency like that, we just need to find ways to help them and support them. And sometimes out in the community, I mean, you can find many different resources that they can support each other. And that's basically what we did. In collaboration with the stakeholders, we reach out to the community and we provide spaces, private spaces with laptops, with hotspot, so the families can basically connect and do their telehealth visit.
Great, thank you. So I'm going to pivot a little bit to try to summarize some of the questions that have been coming through in the Q&A from our participants. So this is probably questions most appropriate for Sansani and Rosani. Can you speak to the technology or the modes that families are using to access telehealth and prefer to access telehealth? And can you speak to any modifications and adaptations that are being considered for populations with disabilities? In particular, one of our attendees was asking about ways that we can think about making sure telehealth is accessible to populations who may be deaf or have vision impairment.
Sure, I can take a stab at it from the CHOP perspective. At the beginning of the pandemic, when telehealth exploded like it everywhere, we very quickly realized that we did not have an easy way to get interpreters onto video visits. So very, very quickly, within the first few months of the pandemic, we worked with our IS team. We created a group of folks together and figured out how to get CHOP interpreters, Spanish interpreters specifically, but others as well too, onto video visits. Now that said, there are CHOP patients speak over 100 languages, and there were some languages for whom we could not easily have a CHOP employed interpreter join the video visit. And so we created this, I have to admit it, very wonky, very tedious workaround way to get an audio interpreter onto the video visit for some of the more rare or orphan languages. And that is very, very challenging. As somebody who works really hard to make it easy to do the right thing, it's not easy to get some of the more smaller population number of languages onto a video visit still to this day. And then for families who prefer, who need ASL, American Sign Language, or perhaps two sign language interpreters, one maybe from a clinically deaf interpreter to ASL, and then maybe to Spanish, so it's maybe 3 different languages. It was very challenging, and we had to come up with some fairly creative workarounds to email links and to pin windows so that the family had the ability to prefer which window was going to be the biggest window to be able to see the sign language needs, the interpreter. So those are, and all of that, of course, came birth out of our families and experts who take care of patients in this particular population with these needs. It still is not perfect. I think there's still a long ways to go to meet those needs, but at least that's where we are, current state, and what we've been doing. The other thing that we heard loud and clear is that it is extremely challenging to go into the app to join the video visit. It's completely counterintuitive to the way that we do Facebook or FaceTime, Messenger, WhatsApp, where an incoming call comes in and we pick it up. It's very counterintuitive. And over the years, we've been able to now have the ability to text out a video visit link to families, and not only to the parents, but also now to foster parents or to other guardians as well, too, as we know that there are more than just mom and dad in the lives of our patients. So we have realized that using that text-based door is just that much more equitable, accessible to our families. And so those are just kind of in a nutshell different video visit modalities. I will say, David, telephone, telehealth encounters are fully implemented and operationalized in subspecialty care, but not so much in primary care because it's not reimbursed in primary care. And so we hear that from families. We hear from myself and the providers that it'd be great just to be able to do a telephone encounter and have it that be a telehealth encounter, but it's not reimbursable. And so then there are those kind of constraints and incentives that then say, okay, well, we're just not going to do actual telehealth by telephone in primary care. Subspecialty can do it. Kind of those differences. So, Kate, those are a few of my thoughts.
Great. I'm going to let Rosani see if you have anything to add to that from your perspective, but then I do want to speak a bit more about that payment piece and bring David in to talk a little bit about making sure there's payment ongoing for telehealth and thinking about some of those payment parity issues.
Yes, so quickly, I mean, I think based on the surveys and the interaction with families, I think the device that that is the most common is cell phones, obviously. Pretty much all families have cell phones right now. But I mean, we find that many of them doesn't even know if that cell phone qualify for a telehealth visit or to be able to use it through a telemedicine. And that's why we developed that whole curriculum, starting with, are you connected? I mean, that first module is, how can you connect your device? How do you know if your device is the best one to do or conduct a telemedicine? And then how can you see the provider? I mean, we try to, basically all the barriers that the families have shared with us, we try to put it into this curriculum where it walks the family step by step on how to connect, how to find the device that they need, and how they can see the providers, what the different platforms they may use, how to create a login information. I mean, what information do you need? And then actually the last module is, how do you do your first telemedicine appointment? That curriculum is available in English and Spanish, but before we actually launch that to the families, we recruit a group of different family leaders that represent different communities. Like we have Hispanic, we have immigrants, we have, different communities that speak different languages, and we share those curriculum with them for them to give us feedback if this is really resonate to you, if this really cover the needs of your community. So we need to go back and make a lot of adjustments just to make sure that they are culturally adapted to them. In the translation, we did that too. I mean, I translate the entire curriculum, but I need to make sure, I'm from Puerto Rico, so my dialect is completely different than Colombia or, another Latin American Hispanic population. So we need to make sure that the translation are accurate and resonate to all the different communities. So let me see her name, Sassini. I don't know if I'm saying it right. She was saying, it is a lot a lot of work that we have to still work on, but I mean, we're doing it, and I think that's what we have to keep swimming and keep helping families and support them.
Yeah, to harken back to some of Sansoni's earlier comments, really thinking about that co-design and thinking about that end user, engaging them throughout the process as you're refining and trying to improve these processes. So going to the payment piece, I think it's important to circle back around to that. So David, from your perspective, can you comment a little bit on what you think is needed in terms of payment, what the current landscape is, and especially now that the public health emergency at the federal level has officially ended, what that looks like and what you imagine for that going forward?
So I actually think obviously the payment is lagging in some ways. I think that tends to come second. I think a lot of times policymakers don't incorporate that into their thought process. So what they'll do is they'll just go from like the regulatory structures around that sort of govern the professions and say, okay, this particular provider group can now provide telehealth and they can do it under these circumstances. And then what often gets left behind is that business aspect of this that we all have to deal with, right? In terms of how does then that provider get paid for the work that they're doing? So I think a lot of times the public sector policymakers are really focused on the customer experience, the consumer, the constituent experience of this, and trying to make sure that their constituents can get access the way that they want to. So that tends to get missed, and then what happens is there's just a lag there, whether it's billing codes not being developed in time, whether it's, you need new contracts to be developed to agree to pay for these things, and it can sometimes lead to, I know when I would do legislation before or regulations around the health insurance industry, a lot of times it was, well, we need a year because we can't renegotiate our contracts or whatever with the health system for another year. So I really just think it tends to lag or gets missed entirely, which is how you maybe see an instance like it was described earlier where primary care reimbursement for telehealth isn't happening or isn't able to happen. So that's really the challenge that we face, where it is just sort of understanding that element of it and how to get the insurance companies to pay for this sort of things. And it probably shouldn't be a surprise to the people on this call, but there tends to be a resistance by insurance companies to pay for things. They don't, make money by putting more of it out than they're bringing in. So a lot of times it has to be something that is told to them that they have to do before they start doing it, or shown to them that they're going to get value in paying for this sort of thing, that they may have cost savings somewhere else. So, that's really been my experience of it, is just making sure when you are developing these policies, and as this continues to evolve, that insurance piece is sort of always incorporated into the decision making right alongside the provider experience to this and the patient experience to this, is then make sure every step of the way you're looping in insurance companies to then say, how do we need to work with you to make sure that the providers are getting reimbursed for this care so that it maintains that access point for the patients? Because coverage is access. I mean, we talk about equity of technology and all that, but a real component of access is the ability to pay. And that needs to be taken care of as well with this. Otherwise, providers are going to say, sorry, I can't do that because I can't get reimbursed for it. And the patient loses that access point.
And I imagine, just to bring in the conversation about equity, that you're negotiating both, particularly in the child health space, with thinking about Medicaid providing coverage for disabled and low-income children, and then thinking about negotiating and encouraging private insurers, and to have that done across states at the state level. I don't know if you have any thoughts about that piece.
I'll get into that because that's a real challenge too, in terms of what sort of policy states can regulate. We can do a lot in the Medicaid space. It needs federal Medicaid CMS approval for a lot of those things, but there's a lot of flexibilities. And then we can say, typically that we want to have Medicaid do a certain thing or reimburse for a certain service. And CMS is usually pretty generous in allowing us to do that. But a lot of the plans that are regulated within state code, within state regulations, departments of insurance or departments of health, whoever is the regulatory authority around them, is very limited as well, because these large self-insured plans that exist at a major company. I think here in Delaware we have a very large presence of banks, a JP Morgan or a Bank of America, right? These are all large self-insured groups that are governed by federal policy and federal regulations. And so when, as a state government, if we say, okay, we think all insurance policies, health insurance policies in Delaware need to reimburse for telephonic, telemedicine delivery and primary care for children, we can only do it for the plans that we can regulate, which immediately then eliminates about half of the lives covered in the state, because they're all under these federally regulated insurance plans. So that's a challenge too for policymakers, is what you end up with is a patchwork where someone can change jobs and suddenly something that was covered before isn't covered now, even though you would think it should be. And you may call your state policymakers and say, hey, why can't you get this covered? And it is, well, we passed a law that says it has to be, but it only applied to these plans because by law we're not allowed to regulate these other ones. So it's a patchwork process, and it feels a lot of times like whack-a-mole, where you hear maybe an anecdote and you think, I'm going to develop a policy that closes that access loophole or whatever that was explained to me, and then you realize, okay, you either maybe created another one, or because of some Supreme Court ruling from a decade ago has told state governments they can't regulate certain plans. So it is a challenging environment to govern in and to regulate in, because you have all these different authorities that are sort of in charge of the sector of health insurance.
Now we only have a few minutes left, but I just want to ask maybe one follow-up to that, which I think is it speaks to the importance of data collection on just monitoring for equity. So maybe we'll start with Sansini. I know some of your work has really been thinking about metrics, and then we can open that up a bit.
Yeah, when it comes to health equity work, whether it's telehealth or any other field, the basic, I think, consensus right now is just start by stratifying either your process outcomes, your process metrics, or your outcome metrics by race, ethnicity, language, payer type, and some proxy for socioeconomic status, be it individual social determinants of health data or publicly available census tract data like Child Opportunity Index or Social Vulnerability Index. So just stratify and look to see the gaps. And the takeaway there is you won't know unless you look. And so if you're not looking, you likely are going to be just perpetuating disparities or even introducing new ones. And then when it comes to telehealth, the bottom line is data is messy. It's just messy. There's no standardized way to measure this. I think that traditionally, when we think about the digital divide, broadband and digital device access is number one. That's really important to know. Who has broadband, who doesn't, who has a device, who doesn't. But as everyone on the panel has said before, many people do have smart devices. Broadband, we need to get high-speed internet there. I think the next step, and looking to the next couple of years, is really utilization and benefit divides. So I'm a mom and I have high-speed internet, I have a device, but when I try to go log into the portal or into any type of digital device tool, it's not in my language. Or it is in my language, but it's so complex, I cannot find this thing that I'm looking for. I just need a letter to send to my school nurse that my kid has a peanut allergy and needs an EpiPen. I can't find that letter. I can't enroll my kid in kindergarten because I can't find my health assessment form. So the data points here are, how are we measuring whether people are able to easily use the tools as we've designed it for a particular target end user, and then stratify that, by race, language, payer type. I really despise the term digital literacy. I really think that the onus and responsibility of the design needs to fall on us as healthcare institutions, on software vendors, on government agencies, to create a standard to say, thou shalt not turn out an app unless it's available in any language that a patient would need it in. It's in plain language, it's easy to use, and I think that's kind of what we need going forward, and those are the kind of data points and metrics that we should be looking at.
Great. Well, I think we are about at the end. I think going back to reflect on, some of the themes that we heard so loud and clear, is that equity has to be a consideration from the conceptualization, the design, and not an afterthought. And I think we've seen a little bit about what happens when it's secondary, and all of you have spoken so beautifully on the importance of really, I love the idea of making it a priority and a requirement, that it's not optional, it's not secondary, but critical. And I appreciate all of your perspectives. So thank you to our fantastic panelists today for joining us, and to everyone who tuned in. I want to point out that there were some questions in the chat, especially about some resources, and we have posted responses and shared some of those resources, the Policy Lab communications team. So please review that and take a look at the resources that we've shared as we reflect on this conversation. And I will say the recording of this conversation will be available to view tomorrow. I believe everyone who signed up gets an email with that link, but you can also visit policylab.chop.edu or tune into our social media channels to find the link. And thank you so much for your time and attention today, and thank you to our panelists for sharing such valuable information.